But really, venous congestion is a mechanism that can impact all organs of the body. You know, we of course are commonly seeing pulmonary congestion that frequently lead to hospitalization in patients with congestive heart failure. But venous congestion can affect the kidney, the liver, the gut, even the brain, and the heart, and also soft tissue. So we can see some complications, and we can see those complications both in outpatients and inpatients if they develop some component of venous congestion. And we think that is a mediator that is responsible for a lot of complications that we see in our patients. So we'll, in this presentation, we'll focus more on the importance of venous Doppler on the assessment of heart failure. And as you know, the venous circulation is different from the arterial circulation. The venous circulation is high compliance and high capacitance, and it's a low resistance circulation, and it has a non-pulsatile source. Although if you get close to the right atrium, you begin to see variation in right atrial pressure, and this is commonly known as the CVP waveform, as you can see on the screen with the X and the Y descent, which in fact represent venous return during the cardiac cycle. But because the venous circulation is highly compliant, as you go further in the venous circulation, these variation of right atrial pressure during the cardiac cycle are usually absent. So if you go in the portal vein or the intrarenal vein, you will see a continuous flow without much pulsatility during the cardiac cycle. If you go further closer to the heart, if you go in the hepatic veins, then you will see the triphasic waveform that is characterized and compatible with the CVP, the variation in pressure in the right atrium. Now, when venous congestion develops, there's two phenomena that can be seen. First, the venous return during systole is decreased because the right atria is dilated and high pressure. So when the tricuspid valve closes, there is not this atrial filling that we see in normal situation. So the systolic component of venous return is decreased. All right. So as you see, the pattern of venous return will change. And secondly, because the venous circulation become non-compliant, these variation in right atrial pressure will be transmitted further in the venous system, and we'll see the development of pulsatility in these peripheral veins. So as you can see, this is a normal pattern of venous return. So first there is the atrial contraction, which we can see on venous hepatic vein Doppler as a short period of flow toward the liver during the cardiac cycle. But then the dominant phase is usually the systolic phase, and there's the diastolic phase after that, which is usually of equal or lesser velocity. And this corresponds to the X and the Y descent of the CVP waveform, which is shown here. And then, as I said, as venous congestion develops, the systolic phase will become less pronounced and can even be reversed if there is significant tricuspid regurgitation, can also appear even if there is no tricuspid regurgitation. And you see the pattern change with the dominance in diastole of venous return. And so when you go to other sites, for example, the portal vein, which is a very easy site to assess using a point-of-care ultrasound, you can see here on the screen a normal portal vein, which with minimal portal flow pulsatility and with a continuous pattern during the cardiac cycle. And as venous congestion develops, the variation in venous pressure are transmitted to the portal system, and we see the appearance of portal flow pulsatility, which is shown on screen. And usually when the difference between the maximum and the minimal velocities during the cardiac cycle is greater than 50%, we consider this to be clinically significant. And the same phenomenon can be seen in the kidney. So by performing pulse wave Doppler on intrarenal vessels, we can see usually this pattern, which at the bottom of the screen is the venous flow. You can see that it is continuous during the cardiac cycle. And then after that, it becomes discontinuous as CVP increases because the venous system is becoming non-compliant. And in severe form, there is only a venous Doppler signal during a short period in diastole, which is the severe pattern, which demonstrates that kidney outflow is impaired due to high venous pressure. So as you can see, those signs, those different assessments can be combined. And if you have an abnormal profile in multiple of these sites, it is highly suggestive of adverse venous congestion in your patient, and that can give you some pretty important information about your patient, about the severity of heart failure. And this can be further quantified. For example, for the venous Doppler, you can calculate the proportion of the cardiac cycle that you see the venous signal, which is commonly called in the literature the renal venous stasis index. And of course, as venous congestion develops, this proportion of the cardiac cycle where we will be able to see venous flow coming out of the kidney will be further and further reduced. So these are not new signs, because most of these abnormal venous Doppler waveforms have been described in the 80s and 90s by radiologists and cardiologists, but maybe because they were described in the lab, the echocardiography lab, or the radiology department, the clinical implications of these signs were not really readily apparent to these physicians. But now, in the last few years, we discovered that when applied with the point-of-care ultrasound philosophy, the assessment of those signs could be helpful in managing our patient. So this is one of the most influential editorial written in 2016 that made the association between those signs in the kidney, in the hepatic vein, in the portal vein, about these venous Doppler alterations suggestive of venous congestion. So now for the remainder of the presentation, I want to take you on a trip, first beginning in the operating room of cardiac surgery, and then moving on to the external outpatient clinic of heart failure, and seeing what are the evidence for these signs, and a little bit more on how they could be used to manage your patient. So I will let Dr. Huard continue the presentation from now on for the moment.
Dr. Lozano, can I share my screen? Oh, yeah, I can now. 1 second. So can you see
we are seeing your screen.
And it says unable to start my video, but I don't need it if ever. Okay, so thank you, Dr. Beaubien-Souligny. So my name is Dr. Karel Huard. I'm a critical care fellow and a PhD student with Dr. Beaubien-Souligny. And during my part of the presentation, I will present studies on these ultrasound markers that were done in cardiac surgery setting in the operating room as well as in the ICU. So as part of this research program presented here, multiple prospective cohort studies were conducted, and I will present some of the main results of this work. But the first prospective cohort study we did included 115 cardiac surgery patients and was looking at portal vein Doppler. So the main objective of this first study was to describe the prevalence of abnormal portal vein Doppler and report associated factors, including hemodynamic and echocardiographic parameters. So portal vein Doppler was performed before and after surgery using transthoracic echo and in the operating room using transesophageal echo. So we showed that abnormal portal flow pulsatility happens frequently in cardiac surgery patients, up to 18% of patients in operating room after cardiopulmonary bypass. We also showed that portal vein pulsatility was associated with hemodynamic and echocardiographic signs of RV dysfunction. Namely, portal pulsatility showed a positive association with pulmonary artery pressures, most components of right atrial pressure waveform, and right ventricular pressures as well. It also showed negative association with mean arterial pressure, cardiac index, and mean perfusion pressure. Also, there was a significant association with RV systolic and diastolic dysfunction on echocardiography. While it wasn't our primary objective in this first study, we found that the presence of portal vein pulsatility was also associated with increased risk of major complications after surgery, even after adjustment for RV dysfunction and pre-op risk factors, and was also associated with longer duration of post-op support after surgery. So afterward, we performed a second study, now including 145 cardiac surgery patients, with the objective to assess relationship between abnormal portal vein and intrarenal venous Doppler and complications, more specifically in this study, acute kidney injury. So in this study, ultrasound assessments were performed before surgery and post-op daily until post-op day 3. Proportion of patients with normal and abnormal portal vein and intrarenal vein is presented here. The second study showed that the risk of AKI was higher when portal pulsatility or abnormal intrarenal Doppler were present on admission to ICU after cardiac surgery. In fact, likely congestive AKI etiology in that context. Then came the question, can these observations be reproduced in other centers? So with international collaboration, we performed a multi-centric prospective cohort studies with participation of 11 centers in multiple countries. And in this study, 373 patients were included, and portal vein Doppler was done in OR before cardiopulmonary bypass, called T1, and after cardiopulmonary bypass, called T2. And here, the distribution of portal pulsatility before and after bypass is shown. And we found that abnormal portal vein at the 2 time points were associated with a longer post-op support requirements after surgery. And its presence post-bypass was also associated with more post-op major complications. This graph shows the relationship between portal pulsatility in T1 before bypass and T2 after bypass. Interestingly, when looking at major complications, if portal vein was normal at T1 and T2, the rate of complications was 19.8%. Then if portal vein was abnormal both at T1 and T2, complication rate was higher at 27.6. However, when portal vein was normal at T1 and became abnormal after bypass, the risk of major complication was particularly high at 40.5%, whereas if portal vein was abnormal at T1 but normalized after bypass, complication rate falls back to similar rate as the normal pre and post bypass at 23.7%, which was an interesting finding. More recently, there has been interest in a new site for venous Doppler interrogation. In 2020, our group published this case report titled Doppler Interrogation of Femoral Vein in the Critically Ill Patient, the Fastest Potential Acoustic Window to diagnose right ventricular dysfunction. This indeed came from our observation that compared to other sites of venous interrogation, the femoral vein is an excessively simple and fast technique to perform at the bedside. We designed a prospective cohort study to investigate the significance of femoral Doppler in cardiac surgery. Our study protocol is presented here, where a Doppler assessment of femoral vein was performed before surgery and post-op day 0 and post-op day 1, with outcome measured at day 28, with 150 patients included. So we analyzed the femoral Doppler as followed. When only respiratory modulations were present on femoral Doppler, the pulsatility was considered as 0%. When both respiratory and the cardiac modulations were present on femoral Doppler, maximal and minimal velocities were measured at the end of expiration, which gives us a pulsatility of 33% in this example. And this last example shows cardiac modulations only with a component of retrograde flow, which gives us a pulsatility above 100%, 131% in that example. So pulsatility fraction above 100% was used to define abnormal pulsatility in accordance with definition used in previous small studies. So success rate of the technique was excellent, from 98 to 100%. Distribution of femoral pulsatility is presented here. So pulsatility was present in 20% of patients pre-op, 31% post-op day 0, and 44% at day 1. In terms of post-op complications, pre-op femoral pulsatility was associated with a higher proportion of AKI and major complications. For duration of post-op support, pulsatile femoral flow pre-op had longer durations of mechanical ventilation, vasopressor requirements, ICU stay, hospital stay, and a composite of post-op support duration called the T-pod. And finally, on multivariate analysis, the association between femoral pulsatility and the T-pod remain statistically significant when adjusted for pre-op risk factors. With all this work on venous Doppler, we noticed that every anatomical site of Doppler assessment can have specific limitations and false positive results for different reasons. Therefore came the idea that combining multiple Doppler signal with the hypothesis that combination will perform better than interpreting venous Doppler every site in isolation. So doing so, we developed the venous excess ultrasound grading system that we called the VEXUS. So how the score works, basically, first you need to have an IVC above 2 centimeters, which is sort of an entry criteria. And then the score will depend on how many severe abnormality of venous Doppler you have on the hepatic vein, the portal vein, and the intrarenal vein. So 0 out of 3 will be a grade 1, 1 out of 3 will be grade 2, and 2 of 3 and above is grade 3, which is considered severe congestion. So applying this score to our cohort showed that VEXUS grade 3 was highly specific to predict AKI in the post-op period, which indeed performed better than other ultrasound markers taken in isolation. Of note, the sensitivity is low at 27%, because there is no gold standard for congestive AKI. And as you know, AKI can develop because of multiple other reasons, so the low sensitivity is not surprising in that context. The score also performed better than CVP measurements. So now we showed that these ultrasound markers are associated with adverse outcomes, but now comes the question, is there something that we can actually do about it? So there are multiple potential applications of venous Doppler in operating room and in the ICU. So for example, for optimization of pre-op risk assessment, for early detection of congestive physiology in your patients, later on post-op to diagnose the congestive complications when they occur and to identify congestion as a potential component of ongoing organ injury. In terms of potential preventive intervention, there is pre-op optimization, restrictive fluid strategy when appropriate, inhaled pulmonary vasodilator or use of inotrope can also be done. And for potential therapeutic intervention, well, negative fluid balance can, when appropriate, can be done. And also repeated ultrasound assessment to help titrate interventions.
Thank you, Kat. So now let's leave a little bit the world of cardiac surgery and the intensive care unit, and let's go to the patients who are inpatients but not critically ill, and outpatients with known heart failure, and see what's the evidence there. So here is the a very interesting study by a Japanese group done in 2016. In this cohort study, UdeA and colleagues studied more than 200 patients who about three quarters were hospitalized patients, but also outpatients. And they assessed the pattern of intrarenal venous flow in these patients who were known for congestive heart failure. And as you can see, here is the Kaplan-Meier curve according to the underlying intrarenal venous flow patterns and the risk of death from cardiovascular cause or unplanned hospitalization for heart failure. So you see this clear relationship between increasing severity of intrarenal venous flow alterations and adverse outcomes in this patient's population. If we only look at inpatients, this is another confirmatory study about intrarenal venous Doppler, which was published by Hussein Syed and colleagues, studying the patterns of intrarenal venous flow in more than 200 patients. And in this study, there was 1 month follow-up of these signs after mostly after discharge from the hospital. And as you can see here, these abnormalities can be found both in heart failure with preserved ejection fraction, heart failure with moderately reduced ejection fraction, and heart failure with reduced ejection fraction. This is perhaps unsurprising because we know clinically that venous congestion can occur even if the left ventricular ejection fraction is normal. So as you can see in this cohort study, there was a clear relationship between the renal function, the EGFR, and the appearance of these signs. And in multivariable models, each decrease of this renal venous stasis index between the indexed visit and the 1 month follow-up was associated with improvement in kidney function during this period. So this is a good reflection of the fact that when you find these signs, it probably rule in the possibility that this patient has an impairment in kidney function due to venous congestion. There was also studies done in pulmonary hypertension. So this is a study done in patients undergoing right heart catheterization. And again, they looked at the pattern of intrarenal venous flow, but also the renal venous stasis index, which, as I said before, is the proportion of the cardiac cycle in which venous flow is detectable by pulse wave Doppler. As you can see, there is some overlap. So if you see here the different patterns, pattern 0 or 1, which is usually considered normal, pattern 2, which is biphasic flow, pattern 3, which is only flow during diastole. And you can see that if we consider the renal venous stasis index, there is some overlap, but as you can see, the monophasic flow patterns is usually much more severe. And you can see also, as you very reminiscent of the previous curves that I showed you, when we consider mortality or morbidity related to pulmonary hypertension, the pattern of intrarenal venous flow was highly predictive of the complications in these patients. And again, if we compare the different tertile of renal venous stasis index, we saw that patients in the third tertile were much more likely to have an impairment in kidney function that is probably due to venous congestion. Again, this is a confirmatory study done specifically in the outpatient clinic for congestive heart failure in more than 200 patients. And again, Kaplan-Meier curves, very reminiscent of what I've shown previously, with the presence of a severely impaired intrarenal venous flow being quite a bad prognosis sign in congestive heart failure patients. Now, in the outpatient clinic of cardiology, one technique that we use more and more is lung ultrasound. Lung ultrasound enables us to detect some artifact called B lines that are proportional with lung congestion. So it makes sense that we would want to combine those point-of-care ultrasound assessments. And this is what I think the first study investigating this in a cohort of patients on the external clinic that are already known for congestive heart failure. They combine VEXAS, IVC, and lung ultrasound. And as you can see, those signs are not found, they can be found in the same patient, but some patients will only have lung congestion, and some patients will only have the abnormal venous Doppler ultrasound signs. So we can really distinguish between lung congestion or systemic congestion using this point-of-care, multi-organ point-of-care ultrasound examination. And again, both pulmonary congestion and abnormal signals in intrarenal venous flow are associated with adverse outcome in this cohort. Lastly, the appearance of these abnormal venous Doppler signs might tell us other things about treatment response. And one of the most important, interesting component is diuretic response. So there has been some animal study and some human study that have previously shown that with increase in kidney congestion, people respond less to diuretic treatment. It is a reason for diuretic resistance. So this is a study done in heart failure patients who received fluid loading followed by 1 milligram of bumetanide. And as you can see, with patients with high venous impedance index, which is another marker of the alterations in intrarenal venous flow, there was a lesser diuretic response in response to the same dose of diuretic treatment. So really, we have a continuum between a patient that has a normal intrarenal venous Doppler waveform that will be diuretic responsive and that is at low risk of congestive acute kidney injury, and the patient who have severely impaired kidney venous return that may have diuretic resistance that we can anticipate, and that is at much higher risk of congestive acute kidney injury. So as Karel, as Dr. Huard said earlier, it's not only sufficient to make the correlation between those venous Doppler markers and adverse outcomes because they can only be representative of the severity of underlying heart failure, and they could be equivalent to other signs such as CVP, peripheral edema, or natriuretic peptide. So we can wonder how these signs can be integrated in our decision process while managing heart failure patients. So at my center at the CHUM, I take care of congestive heart failure in a cardio-renal clinic where we see patients with both heart failure and kidney failure with cardiologists at the same place at the same time, and we take concerted decisions. And the most common context we see is the heart failure presenting with a rising creatinine. And then in this context, it could be due to multiple things. It can be due to hypovolemia. It can be due to congestive cardiorenal syndrome, or it could be due to overtreatment with pillars of heart failure therapy. So sometimes it is evident what is the underlying mechanism of the rising creatinine, but as you are also clinicians, so in some patients it is much less clear, and physical examination and history will have minor contribution in our differential diagnosis, and that's when focus becomes very useful at the bedside because it can differentiate between those causes and maybe orient your treatment that will be different according to the mechanism that led to the what we see on the laboratory measurement of creatinine. So we combine both lung and venous Doppler, and we can then identify some phenotypes. For example, if there is a patient with a rising creatinine with both lung congestion and a high VEXUS, so abnormal venous Doppler ultrasound signs, then our suspicion that it is congestive cardiorenal syndrome becomes probable. And we can also expect that this patient may have a reduced diuretic efficiency because of kidney congestion. It is patients that are very high risk of acute decompensation and hospitalization. So in this case, we can choose to give IV diuretics in an outpatient basis or perform an important increase in oral diuretics to avoid these complications in a timely manner, and prepare a very short-term follow-up matter of days to see the patient again and see if the congestion is relieved. In contrast, if we have, for example, lung congestion, but a normal VEXUS exam, we can anticipate that if the creatinine rises, it's not because of congestion, and we can expect a normal diuretic response. So then maybe we'll choose to maybe moderately increase oral diuretics, but we will be much more careful, and we will still plan for an early follow-up and test for other causes of AKI because congestion is probably not the reasons why the creatinine is rising. And then if the exam is normal, no lung congestion, normal venous Doppler signs, then congestive cardiorenal syndrome seems improbable. And also a normal diuretic response is expected, but probably that it's not warranted to increase the diuretic dose. And again, we can prioritize other tests for AKI, for example, ruling out obstruction or reviewing medication lists for nephrotoxins and individualized follow-up depending on the clinical context. So it's the next frontier to determine how these assessments can modify management and in what proportion of case this information from point-of-care ultrasound will contribute to our management of these patients. So we're beginning a new study in which any physician performing VEXUS exam and venous Doppler exam can contribute. And if you are using this examination and you want to contribute to this study, you can scan the QR code and preemptively register to be a participant in this study, which is called VEXUS Users. And we aim to recruit a lot of VIXUS users to really understand how this exam impact decisions. And there is no trials yet integrating venous Doppler assessment, but we have some preliminary trials integrating lung ultrasound. And you see that integrating lung ultrasound to your cardiology clinic seems to have an impact with two pilot trials showing that it seems to reduce urgent heart failure visit to the emergency room and rehospitalization in patients with known heart failure. So I think focus will become really a mainstay of patient management in the cardiology clinic, and that will significantly improve care for a patient with heart failure. So in conclusion, venous Doppler alterations are prognosis marker. It can be used to identify new onset or worsening of right-sided heart failure. It can be used to determine if we have congestive organ dysfunction, particularly kidney cardiorenal syndrome. And it could probably also anticipate diuretic resistance. And it is rapidly evolving since 2018. And we hope that through collaborative research, we continue to drive the field forward, and that focus will help us help operations. So thank you so much. This is an image of Quebec in Canada in the winter. So I hope that you will have an opportunity to visit sometimes in the future, and maybe not at this time of the year, but maybe at some point where there's less snow. Thank you so much.
Dr. Reyes, Dr. Kai, thank you so much for your excellent presentation. This is an amazing topic in the cardiovascular area. We had a lot of questions. We're going to try to respond as much as we can. First of all, one of the residents of internal medicine of our university, they want to tell you, because in the VIXUS protocols, there are many of the parameters that are predictors of the increase of the right atrial pressure, and maybe también with other outcomes. What do you think that which one of these parameters are more informative to take decisions in our practice?
So I guess you speak about the different assessment of venous Doppler, portal, intrarenal, and hepatic vein waveform. And I guess, in the cardiology literature, they studied more intrarenal venous flow Doppler alteration. In the intraoperative literature, we studied more portal vein Doppler. But I think both are important. And one of the reasons is, as Karel mentioned, it's very good to confirm your finding to another site, because in some case, you can have one abnormal findings and the other findings are normal. And then your suspicion that significant congestion is present is lessened. This can happen, for example, in young healthy patients with a low BMI. We sometimes see pulsatile portal vein, but for example, the intrarenal vein Doppler will be normal. So maybe if you have some echocardiographers, you see this also with the healthy young individuals who have a large IVC. So as the basic idea of VIXUS is looking at different sites to be more sure that your assessment to your interpretation of the assessment.
Okay, I got a question about performing the focus in post-surgical patients, but the patient has also a pulmonary artery catheter. Do you think that the focus brings extra information, or if we have the pulmonary artery catheter, it's not necessary to make the focus in these kind of patients?
Yeah, this is a good question. You're right that in the intensive care setting, you have a lot of source of information, and you can wonder if venous Doppler add to the information you already have. Some of the data that we obtain in cardiac surgery is very interesting in this sense, because we saw with the VEXUS that it was more predictive than usual CVP cutoff of 12 to predict the development of acute kidney injury. So we kind of think that the appearance of these abnormal venous Doppler waveforms really assess the impact at the level of the organ, and this is useful complementary information compared to invasive central venous pressure measurements. But your comments is, that's why, partly why we're doing the VEXUS user study, because we want to assess when you have all the information, when you add the venous Doppler information, does that modify management or not?
Thank you so much. The specific question is so interesting because, as we know in the VEXUS protocol, we start with making the dimension of the DCI. And if the DCI is normal, we finish the protocol. Could you explain if there is a possibility that we have constraint where we have congestion exactly abnormal portal, abnormal hepatic, or abnormal renal Doppler with a BCI normal?
Yes, so you're right that there is some potential caveats to the VEXUS grading system, and one is the IVC dimension cutoff. And you're right that in some contexts, for example, patients of short stature, the IVC could be dilated, but it could be less than 2 centimeters, or patients with intra-abdominal hypertension. So if you have intra-abdominal hypertension, it will push on your IVC and it could look less than 2 centimeters, and you could still have the abnormal venous Doppler waveform. So we're kind of refining this definition, and we can, the plethoric IVC as a particular appearance on point of care ultrasound. So I guess the only message that I want to share is that if you have an IVC that doesn't look plethoric, that is the important variation during the respiratory cycle, that seems compliant, but you have abnormal venous Doppler signs, you should double check, because it doesn't make sense if the IVC is very compliant that you have abnormal venous Doppler signals. So you should have an increased degree of suspicion and double check, do I assess the right vessels? Is that an artery that I'm assessing? Double check your work.
Okay, Dr. William, I have a question about the renal resistance index, because in some of your papers, you describe it like a good parameter to predict renal failure. Being so, do you consider that it should be part of the measurement in all patients, and when we're doing a VEXUS, make the renal resistance index, or is there any reason why it does not appear in the approach of the VEXUS protocol?
So the renal resistive index, the problem with the renal resistive index is it is very unspecific. It can be influenced by multiple factors. For example, pulse pressure. So if you have a patient with aortic insufficiency, or an elderly patient with a large difference between the systolic and the diastolic blood pressure, the renal resistive index will be increased, but this has nothing to do with the kidney. It has to do with the systemic hemodynamics. So it's very difficult to interpret one renal resistive index in isolation. But you're right that with congestion, the renal resistive index can increase. It can increase with obstruction. It can increase with acute tubular necrosis, so AKI. So I wouldn't say that it is a required component, because there are so many things that can affect it that it is very difficult to interpret in a clinical setting.
Thank you, Dr. William. There is a question in the chat. Dr. Sergio asks if there are any considerations in the Texas protocol in patients with pericardial disease, specifically with constrictive physiology. What do you think about that?
Yeah, so there is interesting consideration. One of the unique thing that we can see with pericardial disease is a very singular appearance of the hepatic vein waveform with a reversal not in systole but in diastole, and diastolic reversal in the hepatic veins. So it can really modify the venous waveform. Of course, if you have loss of venous compliance of the venous system, those waveforms will be transmitted to the periphery. So you could have a pulsatile portal vein or disturbed intrarenal venous Doppler related to, for example, related to pericardial disease. There has been some case report where after addressing this phenomenon, there is a rapid normalization of the venous Doppler waveforms. So yes, it can definitely modify the venous Doppler, and even when you have ECG and hepatic vein Doppler waveform, you could even suspect that there is a pericardial disease just by looking at the waveform. But I'm not sure what is the sensitivity and the specificity of this type of sign.
Perfect. There is another question about the limitation of the vector in some kind of patient, a specific patient with cirrhosis or atrial fibrillation or patient with pacemakers. How should we overcome these limitations in the interpretation of the vectors?
So you're absolutely right. In cirrhosis, we don't quite know if we can anticipate that the portal Doppler will not be reliable. And you're absolutely right that we now tend to study whether jugular or femoral, as Carol presented. So Dr. Roa talked about femoral Doppler. It's really an interesting assessment because it can relieve some of the limitations. For example, portal vein in cirrhosis patients, or also the other limitation that it can help with is that in critical ill patients, renal Doppler becomes very difficult to do. So we're thinking about, for example, replacing the renal Doppler component by the femoral Doppler assessment in patients where one component of the VEXUS assessment is thought to be unreliable or technically difficult to perform.
Thank you, Dr. William. One of the last questions is about what do you think that which consideration should we have in intake in the evaluation of the congestion in patients with right heart failure?
I'm not sure the learning curve, I'm not sure I got this question. Can you repeat?
Yeah, which considerations should we have in intake in the evaluation of the congestion in the patients with right heart failure?
So what other considerations?
Exactly. It's specifically in the patient with right heart failure.
Yeah. So one thing, since I take care of a cardiorenal clinic, there has been some patients with very severe right heart failure that the VEXUS would be positive no matter what you do. So there has been over longitudinal follow-up, we've learned that for these patients, you see that the portal vein is pulsatile, but no matter what change you perform, diuretic-wise, it will not be modified. So in these very severe cases, of course, these patients are at at a high risk of adverse outcomes. So that more a marker of severity. So if you see a patient with a very severe pulmonary hypertension or right ventricular failure, having a positive VEXUS assessment doesn't necessarily mean that you should push diuretics as long as the VEXUS score is positive. In some case, you might want to try it, but you must take into consideration the evolution of the patient, and in some case, the VEXUS will be the venous Doppler alteration will be always there, and they will not be modifiable.
Okay, thank you, Dr. William. There is no more questions in the chat. Dr. William, Dr. Kyle, thank you so much for accepting our invitation. We are very grateful for the message shared today, and we hope to be able to promise you future opportunities. Thank you so much.
Thank you so much.